Hello, everybody. Welcome to an overview of the Pathways to Health and Homes program, the City of Sacramento's Whole Person Care pilot. My name is Lisa Chanson. I am the project director of the Pathways program and also the CEO and principal of Transform Health. We are a nationally certified women and minority-owned consulting firm focused on systems transformation issues in healthcare today. We are mission-driven with flexible rates, and we are quite excited to share with you one of our key projects that really looks at how we can integrate across systems and create better workflows, processes, and a new system of care for those who are homeless. So Pathways to Health and Homes is a program that specifically serves high utilizers of the healthcare and EMS system. We serve those who are both high utilizers and who are experiencing homelessness today. And on the screen, you'll see here Jamie, one of our patients. Jamie suffered a major stroke nearly 2 years ago. He was an up-and-coming, budding local chef. And after his stroke, he lost significant movement on the right side of his body, really struggled, became severely impaired, and could no longer support himself as a working chef. Working through one of our local FQHC partners, Sacramento Native American Health Center, Jamie was connected to a multidisciplinary team who really supported his ability to stabilize in the community and be able to return to work and self-sufficiency back in the community that we are all in. So what is whole person care and Pathways to Health and Homes? Whole person care is a Medicaid Section 1115 waiver pilot in the state of California. This pilot focuses on high-risk Medi-Cal beneficiaries who are frequent users of multiple systems of care and still experience poor health outcomes. It provides flexible funding to achieve the triple aim: better health for populations, better care for individuals, lower costs, and really the provision of care at the right time, in the right place, in the way patients want to receive care and services. There are currently 25 whole person care pilots across California, 24 of which are led by counties. We are the only city-led pilot in the nation. So Pathways to Health and Homes is the City of Sacramento's whole person care pilot. This program is about providing pathways and supporting patients as they seek to improve their care and address their housing needs. This pilot identifies a specific target population, and we assess their health and social service needs and really strives to promote coordination across a community where the patient is being served by multiple providers at the same time. This is done through sharing data, collaborative leadership, and greatly increased coordination of care and services across sectors. In our program, we specifically focus on bringing the healthcare industry and the housing industry together to create a better system of care for those who are experiencing homelessness in our community. We developed a shared mission and vision with all of our stakeholders in both health and housing industry because we realized that to be able to address homelessness, we really needed to engage all of the partners and the players within both of these industries to move the dial in the same direction across all health and housing programs serving this population. On the screen, you'll see that our shared mission and vision really intending to support Sacramento's most vulnerable individuals through a fully integrated system of care. And our vision is to be in a city where all individuals have access to a home and adequate health care. So our target population are Medi-Cal enrollees or eligible individuals who have yet to be enrolled in the Medi-Cal program, who are experiencing homelessness, and are also individuals with complex healthcare needs. Many of our patients are frequent users of emergency rooms and inpatient services at our local hospital systems. Many of them are amongst our most vulnerable and unsheltered, and are high-risk individuals exiting institutions. This pilot is funded through a combined partnership with the federal government, and was awarded a $64 million allocation to implement this pilot between July 1st, 2017 through December 31st, 2020. The city and its partners collectively contribute funding for the program, and that is matched through an intergovernment transfer process with the Federal Center for Medicaid and Medicare Services. So how did we come about? We brought the partners across the city together using a collective impact approach. We recognized quickly and early on that this was not a problem that we could solve individually within the city or with a subset of partners. Really, what we needed to do was bring all the partners together and talk about how do we collectively share data and better support patients. And so to do that, we set up a governance structure. The governance structure on the screen you'll see is all of our partners participate in a steering committee and act as an advisory body to the city. Decisions are made through an executive committee of city staff and leadership, and the executive committee provides direction to the program director and the project support team, which is staffed by Transform Health. We also hold ad hoc IT committee meetings with all of the partners and a transition work group meeting, formerly our service delivery committee. These committees are really important because we leverage those committees to bring our partners together to support the design and evolution of our program. All of our partners, their leadership, as well as the project managers and frontline staff, participate in these governance committees. For example, leadership of our FQHC partners participate in the steering committee meetings, providing insight to needs of frontline primary care providers in the community. Their IT leadership supports and participates in our IT committee, where we look at how do we share data, what type of agreements are needed, and use that as the forum for having IT and data sharing discussions across the collaborative. That is the same for service delivery as well as our transition work group. So who actually attends each of these governance meetings? Under the executive committee, this is attended by city leadership. We meet quarterly and is focused on programmatic decision making. They are informed by a steering committee, which are the attendees are partner executive leadership, and they serve as an advisory body and meet quarterly. IT committee does plan and operationalize IT infrastructure and needs. We discuss data sharing agreements, and this is attended by partner IT leadership. And finally, our transition work group, which is formerly a service delivery committee. This is attended by our partners' clinical and or programmatic leadership. And this is where we talk about actual service delivery functions, design our care plan, and all of our partners have a voice in the design elements of the service functions we carry out. As we near the end of the program, we've converted the service delivery work group into a transition work group to focus on how do we execute a program transition where we safely and securely transition patients into subsequent new programming that will support their needs as this program and this pilot ramps down. All of these governance committees are supported by a learning community, and this learning community is comprised of project managers and frontline staff at each of our service partner organizations. These are the people who are doing the work in our community and where the rubber really hits the road. We use the learning community as a way of bringing together frontline staff to share best practices and lessons learned. And the whole goal here is to create a safe forum for us to really engage as colleagues and figure out how to support one another as we implement this model. The learning community is also an opportunity for us to do trainings and provide additional support to our service providers, and it is an important function to ensuring that the model that we are seeking to implement generates the types of outcomes that we are seeking. So let's spend a little bit of time talking about our partner organizations. What we have done is brought everybody in the healthcare industry as well as the housing industry together, including hospital systems, health plans, providers out in the community, first responders like fire and police, as well as housing partners and CBOs who are all touching and serving the same patient. So you'll see on the screen, we have 6 FQHCs and 1 IPA, River City Medical Group, as a partner organization in the collaborative. We also have 4 health systems, Dignity Health, Kaiser Permanente, Sutter Health, and UC Davis Health. They are all not only key partners from a ED inpatient lens, but they are also important partners for us as they are also some of our funding partners. We also engage first responders, fire and police departments. We mainly work with the impact teams in the fire department and police department, which are specialized teams trained to serve the homeless in our community. On the screen now, you'll see our housing partners. Some of these are actual housing service providers, LSS, Sacramento Self-Help Housing, SSHH, and we have one other housing partner which has evolved into a housing organization, Sacramento Covered, which we'll talk about when we talk about CBOs. In addition, you'll see here that we have the Sacramento Housing and Redevelopment Agency. They are responsible for administering HUD housing vouchers in our community, as well as Sacramento Steps Forward, SSF, which is where our local continuum of care is housed. Salvation Army and VOA are 2 additional key partners as they manage a lot of local shelters. In addition, we also have 5 active managed care plans, Aetna, Anthem, HealthNet, Kaiser, and Molina. United was formerly one of our managed care plan partners. However, they are inactive in Sacramento County. We also partner with 2 dental managed care plans, Access Dental and Liberty Dental, to support the dental needs of our patients. And finally, we do engage with a number of community-based organizations, 211, which is an important referral database source of services that anybody can call into. Sacramento Covered, which is an important partner for us as they manage a lot of the outreach and enrollment activities for the Medicaid program in our community, as well as Hope Cooperative, which works closely with the county, particularly for patients with mental health and substance use disorder needs. So let's take some time to talk about the service delivery model. We have a service delivery model that starts with referrals, enrollment, and eligibility, and then shifts into services provided through mobile, community-based interdisciplinary care teams, and which really focus on coordinating access to healthcare, social services, and housing services that each patient needs. Every patient is different, and referrals and enrollment, all of these key functions look a little bit different as we step through the logic model. All of this is supported through a care management platform, which we will talk about in a few minutes. This care management platform is a source of truth, and all providers serving the patient that are part of our collaborative have access to that same care management platform where they have access to the same information. This has been an important piece, particularly when we talk about coordinating services and care across health and housing partners. And for those who like more of the details, on this next slide, you'll see the actual logic model. I recognize this is a dense slide, but this encapsulates the totality of our project, what the inputs are, and our expected outcomes. On the left, you'll see here, we've aligned a number of local initiatives and programs and built out community assets. As part of this pilot, we have a set of activities where we are bringing both industries together through building governance capacity for coordinating and aligning across the healthcare system, behavioral health system, housing, and social services systems for high-risk, high-utilizing homeless individuals using a no wrong door approach, leveraging assertive outreach techniques, and connecting patients to field-based interdisciplinary teams that are implementing a community co-management model. The idea is to engage and activate patients as they are in the community, promote health equity, and align interventions, all supported by our care management IT platform developed to support data sharing capacity and ensure coordination across different organizations that are seeking to serve the same patient. And on the right, you'll see here a set of outcomes that we are trying to achieve by the end of 2020. This includes increased governance, where we have engaged in collaborative partners, improving the interventions and the set of services available to our target population. We are actively developing shared measurement system and sharing data across the partners, as well as conducting quality improvement activities through shared plan, do, study, acts, where we're actively looking at internal workflows, processes, both within provider organizations as well as across the collaborative. And you'll see here we have a set of service delivery targets as well as some longer term goals that we are seeking to achieve. At the end of the day, this program seeks to create long-lasting change in our community, and we hope to work with all partners to ensure that the infrastructure and capacity that we have built through this program is maintained. So I mentioned earlier a community co-management approach. Using a collective impact model, we recognized that there were multiple organizations that were serving the same patients. Sometimes they were providing the same service, sometimes they were offering competing services. We sought to bring all the partners together so that those events don't happen anymore in our community. And our collective impact co-management approach is one where no single organization does it all, but instead work together as a multidisciplinary team, cross-cutting across health and social services to meet the patient where they are. What co-management means is frequent, routine communication between healthcare providers, our outreach providers, as well as providers providing housing services. We do this through shared care planning. We also case conference and create provider huddles so that the communication levels have increased beyond what we typically see when it's one provider managing these sets of services. So together, our hub, outreach, and housing providers co-manage their shared patients together. So some of you may be wondering, what does this actually look like from a patient's lens? And so what you see here on the screen is what patients will actually experience through their journey. At a very high level, we receive referrals from hospitals, FQHCs, shelters, the impact teams, and health plans. The reason for this is because we wanted to focus and target our population to serve those who were the sickest amongst people experiencing homelessness in our county. And we recognized that there were many providers already serving these exact same patients today. So these organizations refer individuals in based on eligibility criteria. Patients are taken through an eligibility determination process by our outreach provider, Sacramento Covered. And this is an assessment process where we gather information electronically that encompasses not only enough information to fill out applications for various social service programs or for Medi-Cal, as well as ask the patient and assess the patient for their health, mental health, substance use disorder needs. We also ask them what their self-determination goals are, what's most important to them that they would like to work on. Enrollees that are deemed eligible, meet criteria, are enrolled, then activated and motivated by Outreach CHW to engage them to set up some initial appointments, connecting them back to care and connecting them to their care team, who then catches them, wraps around them, and seeks to support them as they stabilize in the community. And once they've stabilized, they may be ready to graduate. So there really are 4 phases to patient experience. This begins with phase 1, outreach and enrollment. And this is where our outreach and enrollment provider, Sacramento Covered, really steps in. They send CHWs out to where identified patients are, whether they are in the hospital setting or out in the community, and verify their eligibility. They make sure that they are enrolled in Medi-Cal if they are not already, and conduct the initial intake process, which initiates the engagement, care planning, and goal setting. All of that information is fed directly into our shared care plan and available to the providers when the patients show up for appointments. And then once patients are actually in the program, our clinical hubs, the 4 FQHC partners, ELICA, One Community Health, SAC Native American Health Centers, and WellSpace Health, work in collaboration with SAC Covered, as well as our 2 other housing partners, SSHH and LSS, and seek to activate and engage patients. They have targets where, depending on the acuity level, they are frequently conducting outreach and making sure patients have what they need. For example, they begin coordinating and making sure that the patients who have unmet healthcare needs get into appointments, specialty care, They catch them up on any medication needs and connect them to services that perhaps the patient has been foregoing. Another example is sometimes some patients, particularly those with mental health issues, may be on medications, and those medications are only provided a week at a time to those individuals in our community that are experiencing homelessness. By coordinating with the hub, our CHWs actively engage patients and make sure that patients in that situation have the medications that they need. And this is done through calling them, checking in on them, and if they don't have medications, arranging transportation, arranging for medication pickup, and working with pharmacies. So there are a number of services that we provide during this activation and engagement phase. The way I think about this is we've really given each patient who are struggling and oftentimes have complex care needs. We are giving them not only a coach and a support in the CHWs that are engaging them, but we are also working to wrap around their needs and ensure that they don't have to provide the same information multiple times, or supporting them to collect and hold on to documentation, and really support their needs no matter what it is. This is a key piece of the patient engagement. And once patients are active and engaged, we really see a difference, because during the phase 2 activation engagement phase, we're pushing in and engaging the patient. And once the patient is in the stabilization phase, the intensity of services are lower, and we've caught up with some unmet needs. And patients are at that point really reaching back in and being more directive in their care and really engaging our providers in a more directive way based on what they see are their needs. And once patients are fully stable, we do graduate them, and it's based on key criteria. The graduation decisions is a clinical decision, which our hub partners, in conjunction with the other service providers, discuss before graduating a patient. We also have disenrollments for a variety of reasons. Really, during this phase, patients don't need this program anymore, and they are ready to move on. I will say, of the 4 phases, there are no time limits. The patients can be stabilized and then something happens and maybe they revert back to phase 2 where they need additional engagement. We've also had situations where we've graduated patients and something changes and they can come back on the program as well. So let's take a moment and talk about referrals. Referrals are really important to our program because we have an active goal. We can serve 1,000 patients at any point in time, but these patients must meet criteria. So there are a few things when we're thinking about who is actually eligible. There's a threshold question because this is a Medicaid-funded pilot through a waiver process. All patients in our program must be eligible and enrolled in Medi-Cal, and they also must meet the criteria on the far right, meaning they have to be in Medi-Cal and have had 1 or more inpatient hospital stays in the past 12 months, or they're on Medi-Cal and they have 4 or more ED visits in the past year. Another potential patient set that we have are, they may be eligible but not enrolled in Medi-Cal. And so we facilitate that enrollment, and maybe they have 4 or more crisis interventions, meaning 4 or more run-ins with police or fire, and they would be eligible as well. Because of these reasons, and because there are utilization criteria, we have a very tight referral process. We will talk about that further after we review service providers and their roles. At a very high level, here are our pathway service providers and their roles. As you can see here, Sacramento Covered is our outreach partner. We have 5 care coordination hubs, 4 of which are housed in FQHCs, and 1 which is a virtual hub. This is a partnership between Sacramento Covered and Sacramento County, which runs its own health center. The reason for this virtual hub is because there are some patients who do not have a primary care provider that is in one of these other 4 FQHC hubs. Sometimes these patients are assigned or are seeing a doctor in the community. And so this virtual hub is a way for us to create a care coordination process that is backed by a clinical provider to engage with the primary care and specialty care providers who are not part of the 4 hubs that we see here. In addition, we have 3 housing support services providers: Sacramento Self-Help Housing, Lutheran Social Services, and Sacramento Covered. These housing support providers work in conjunction with a care coordinator at the care coordination hubs, as well as the outreach CHWs, really wrapping around the needs of the patient. 2 other key functions that I wanted to mention is Sacramento Covered also serves as our eligibility and enrollment office, as well as our data management office, housing the shared care plan. We also funded 20 crisis respite beds. These are 24/7 nursing beds that are step-down care intended for individuals coming out of hospitals who do not have the ability to support their care needs as they transition out of hospitals back into the community. Oftentimes, as you can imagine, many of these are patients experiencing homelessness. As I mentioned before, these crisis respite beds have 24/7 nursing. We fund 20 beds in the community in addition to the existing 16. So let's drill down a little bit more about what each of our partners do. We'll first talk about community health workers. Our outreach CHWs are a critical part of our care team serving patients and serve as a constant for patients out in the field and in the community. They provide navigation, linkage, they accompany patients to appointments, they help set up appointments. There's a variety of services that we blend and braid into that the CHWs provide a key role supporting the patient's access to. CHWs also provide a critical linkage to our county mental health and substance use disorder treatment service partners. And, we work through them and through the Sacramento County Health Center to really ensure linkage and access to mental health and substance use disorder treatment services for our patients in the community. CHWs also play a critical role with assisting patients with documents. This includes supporting them to get copies of anything that is needed to engage them and enroll them into various programs that they are eligible for. CHWs work very closely with our FQHC hubs. Our hubs ensure expedited access to primary care and behavioral health services, oftentimes within 72 hours of referrals for individuals with urgent needs. They are the owners of the shared care plan, really driving any care coordination needs as part of huddles with our housing navigators and with our CHWs. It is a unique feature to our pilot where we have actually embedded the CHW and the housing navigator into the hub care teams, and they really work closely to engage the patient and ensure that what has been determined are their care needs in the shared care plan are complete. One of the requirements that we have is the shared care plan has to be developed and completed within 30 days once a patient has been assigned to our hubs. And we really have a collaborative where the hubs offer a lens into and support expedited access to clinical services, while the CHW extends the eyes and ears of the hub coordinators so that they know what's happening to the patient in the community. And of course, I would be remiss not to talk about housing services provided by the housing navigators embedded in our care teams. Housing services are critical in terms of stabilizing a patient and are different than the actual housing itself. So some of these housing services include assessment screening or various programs. They also help patients set individual housing goals and create a support plan, monitor progress in terms of outcomes. They also work with landlords to identify new housing opportunities. Some of our housing partners actually do family reunification, where they try to reconnect our patients back with family and friends or develop group housing situations. They also support our patients' ability to apply for and engage on HUD-funded vouchers, as well as with our local continuum of care. Many of them also support our patients through going to appointment with them, actually helping them move in. And then after somebody has moved in, ensuring that if anything goes wrong, landlords have somebody to call so that our patients are not, kicked out of their housing situation. There's somebody trying to create an intervention. We seek to house as many patients in permanent housing as possible. This sometimes can be subsidized through a voucher. Sometimes it's through shared housing. We also house people through temporary housing situations. This includes bridge housing, transitional housing, respite care, room and board. These temporary housing situations are time limited and are short term. So anyone we house through temporary housing, we actively seek to ensure they still have a housing plan that actually looks at their income and addresses sustainability. All right, let's take a moment and talk about Interim Care Plus program, which is our crisis respite program. Pathways funds 20 crisis respite beds provided through WellSpace Health. Patients are referred into the Pathways ICP beds either through their Pathways hub or as they're exiting out of the hospitals. They may be in there up to 90 days, and these are extensive services coordinated by ICP Plus staff who also works with the Pathways multidisciplinary care team to ensure that Pathways patients have their care planning needs met. To actually be referred into ICP Plus, clients must meet the medical acuity requirement and receive medical clearance by a licensed clinician. Final admission is approved by the ICP Plus nurse, and all ICP Plus discharges are done in collaboration with the Pathways service providers. And this is a visual model of the way ICP works. A patient is referred from the hospital into ICP Plus. Our pathway service providers know that they have to coordinate with the ICP Plus staff who is doing the monitoring, the medication oversight. It's a shelter and clean environment, 24/7 nursing care to ensure that the patient's needs are met. And when they're ready for discharge, the ICP Plus staff collaborates with the pathway service providers to transition them back into other community settings. And the pathway service providers are actively working on a number of items, including patients' housing needs, as well as any other care needs that are in their care plan. The shared care plan that we have built is a concept built through an instance of Salesforce. The goal of the shared care plan was to create a person-centered plan that would address the health, behavioral health, housing, social services, and other needs of each pathway's enrollee. This care plan is filled out across the multidisciplinary care team, which means the housing partners actually really own and share information in a real-time way around the housing needs and interventions and services that the patient has received in the shared care plan. The hubs also document any clinical interventions, and the CHWs are actively documenting any other programs, referrals that we're seeking to build a bridge for that patient into. We have one care plan across all of the providers touching the same patient. This is a cloud-based application. So many of our providers, their frontline staff, are using the shared care plan at the point of care while they're out in the community, which is really wonderful because we want to make sure that this is something that is really driving the care and service needs of our patients. So let's talk a little bit about the outcomes that the Pathways program has generated. On the screen, you'll see our most recent dashboard. We track our data through our shared care plan and generate dashboards to track progress in our program. As you can see here, we've served over 2,000 individuals since the inception of the program. We started enrolling patients November 1st, 2017. This is an accumulation of our services to date as of June 30th. And you'll see here that as of June 30th, we have current enrollments at 921 individuals. If you have questions and would like further data and the most recent information, please reach out to us using the contact information at the end of this deck. On the screen here, you will see one of our patients, which was featured in our local paper, the Sacramento Bee. This patient was chronically homeless, had been homeless for 30 years, and completely disengaged. And our CHWs engaged her. We got her enrolled in the program and stabilized through one of our FQHC hubs. Our housing partners worked with her to address some legal issues to ensure that she could get driver's license and identity documentation, and then enrolled her in a number of programs that she was eligible for once we cleared through those barriers. She is now housed in senior housing, and her diabetes is being addressed, and she is now beginning to stabilize in the community. And this is a typical patient that we see in our program. So let's spend a few minutes talking about some of the best practices and lessons learned through these efforts over the last couple of years. We've learned that a collective impact model that supports organizations working together is absolutely critical. It really allows us to leverage each provider's strengths and their resources. There's a continuum of housing options available, ranging from permanent supportive housing to private market shared housing. housing providers have a different skill sets that help individuals engage in the range of options. And it's become really clear to us that no one service provider can do it all. And by using a collective impact model, we are creating synergies and supporting each other across organizations and creating that safety net that our vulnerable patient population deserves. We also aligned and co-located services, working with the city to stand up a low barrier shelter. This low barrier shelter approach allowed pets, partners, belongings for patients that were critical to ensure that some of our chronically homeless would actually consider sheltering. Once sheltered, they were more open to receiving services, and it was clear that it was easier to help individuals when they were stable and in one place. I also want to share how important our community health workers are. They're often the glue that help enrollees connect to health services and housing, critical to helping with documentation requirements, and really filling service gaps and extending the eyes and ears of clinicians into home and community-based settings. These CHWs really were eyes and ears of our providers beyond the four walls of their clinics. We saw how important flexible housing funds are. A flexible housing pool provides funds for security deposits, move-in costs, application fees. Oftentimes, many of our patients move in without furniture, without groceries, or without even the basics such as toilet paper and paper towels. This is a critical benefit that we have set up through our program and have learned how to effectively administer. Homelessness is a complex issue that no one industry or organization can solve alone. And by pairing our housing supports to stabilize patients and having different industry sectors come together and work together to bridge and maximize efficiencies, created enhanced supports for this population. These are some of our best practices and lessons learned. There are other ones that we've identified. I wanted to acknowledge the City of Sacramento, who is the lead entity. Our firm, Transform Health, is really the consulting firm supporting the day-to-day operations, but we couldn't have done this without the support of some of our other key consulting partners, as well as Sacramento Covered. And many of you may want to learn more. So the Pathways program has its own website, as well as newsletter. Everybody is welcome to sign up for the newsletter. And if you would like more information about Transform Health, please visit us at the location on your screen. We are always excited to share more information and share learnings from this pilot effort that we have worked closely with the housing and healthcare partners in the County of Sacramento, as well as the City of Sacramento. So thank you for your participation today.